Mute me. Mute me. Sorry. 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 All right. Okay, so there are a lot of providers. So there's a high degree for freedom for physicians and patients. What will this mean? So they can pick who their doctor will be, who their patients will be. However, with universal health care and insurance, it kind of gets limited because some will some insurance will limit or only those who are accredited for this certain insurance, etc. can be. Or universal health care, you should be registered to this certain locality. Then you can avail of the service there. If not, you're not part of the list, then you cannot avail. Okay. Few restrictions in the range of services covered by the health insurance system. Okay. Some health insurances, they are just for show. HMOs, for example, and it's one of my pet peeves that HMO will not cover a simple procedure such as pap smear. Why? Because they say it's not a disease. But you know that it's a screening tool. So what can we do? It's not covered. It will be out of pocket unless you do something about it. You just write there's bacterial vaginosis, but that again, that's not being ethical. Okay. And that's a two-edged sword. Sometimes, if it's related to sexually transmitted illness, so you have genital warts, you have chlamydia, etc. Insurance will not cover for that. If it's part of risk behavior, if it's part of negligence. So the fewer restrictions, the insurance, better. Okay. Of course, the ease of access, waiting list, patient satisfaction is also important. So how easy is it to claim benefits? Because if you make it hard for the people to claim benefits, then people will not subscribe to your insurance. Okay? It goes both ways. But in South Korea, they're also known for, although they're the best health system, they are also number one for what? Insurance fraud because of kids. So it's a double-edged sword. But as far as health, they are prioritizing it because I think if they are a policymaker and there's a health insurance claim, it's better to err on the wrong side and give the benefit than to withhold benefit and let a sub-career life. Nothing like that. It's up to the collectors or to the insurance fraud agents to detect who will do fraud. Sometimes even that they fake debt to get debt claims because it's really a lucrative industry. Okay. For this morning, afternoon, so we describe the key elements of a health system, define common terms in health economics, analyze healthcare system and financial situation for the Philippines, and compare advantages and disadvantages of the different forms of health financing. So what are the key components, Kapit, of a well-functioning health system? What do you think? Of course, we want a status of health individuals, families, and communities that would be improved. Of course, the definition of improve will be, will have its own definition. One, good quality of life to one may not be the best quality of life for someone else who wants some who wants a simple life. But for someone who wants a modern life, well, that's completely different. Some would want to be an urban dweller. Some would be happy in the rural setting. So it still depends. But in general, you have to have improved health status. And you have learned in your first year of different indicators. What are your different health indicators that could measure quality of health? Hmm. What are the indicators that you remember? Hmm. What are the rates that you remember? Birth rate, death rate, mortality rates in under 5, under 1, neonatal mortality rate. All of that will be reflective of the health status of a community. Defending the population against what threatens its health. And you have seen this real time. And it changed the health system of every health system in the world. And it affected every health system, crumbled it to pieces. Your pandemic tested the limits of every country's health system. And they had to channel all financing. And see how important financing and economics is. All financing towards combating that pandemic, which we were not prepared for. Okay. Protecting people against the financial consequences of ill health. And this is the biggest cost. Okay. Of course, life is important. But if you have a breadwinner, especially, who eventually falls sick, the opportunity cost for that household falls drastically. Especially, for example, you're a doctor earning 50,000 per operation that you do. You're averaging 10 operations per month. So that is a clear 500,000 a month for the household. You get sick. Even for just 2 months. So that is an income loss of 1 million for 2 months. What if the sickness leaves you incapacitated, disabled, and unable to do work? Your work that you studied your whole life for. You have to reinvent yourself. And you're protecting people against financial consequences of what might happen if someone gets sick. Of course, access is always in question. Access to people-centered care. That's why the trust of all health systems would be to provide universal health care, and that is health care for all. So that it's possible for people to participate in decisions affecting their health and health system. So this is where your community organizing comes to play. Community participation. It's challenging to set up a health system that's very responsive to everyone's needs. Okay. For now, status quo would be disproportionate focus on specialist curative care. Tertiary prevention, tertiary level of care You only treat people when they are sick. People only seek doctors when they are feeling something. Thereby, you already need a specialist like them. You need cure, cannot be preventive anymore. So there's fragmentation, a lot of programs that are redundant, projects that are redundant, and NGOs that are doing the same thing. Why not consolidate all this into one organization so that your movements will be synergistic and you will not waste resources? And like it or not, you have your commercialization of healthcare delivery in poorly regulated systems. And this is fueled by multinational companies, which are often the ones that run your drugs. Because drugs would be $1 billion industry and they have to make their drugs move. So what do these drug companies do? In the guise of helping other people, in the guise of donation, etc., etc., they will have a medical mission. I'm not saying it's bad. They have a medical mission. Everyone who has hypertension will be started on their brand of drug. What do you think will be the effect? Since all of those people will be started on their brand of drug, when these people consume the drugs that they were given, when they buy again, what are the chances that they will buy the same drug? Higher or lower? It's higher. Some may change brand, but especially if the effect was that they felt that there was a change, they will tend to buy that same drug that was used. Initially for free, but the subsequent doses they will buy. And that is how drug companies steamroll their sales. Well, that's part of marketing. Okay? That's how they play the system. Okay. And it's hard to keep it on track. That political will to maintain direction and focus for your health system, making a coherent investment in the various organizations within the health system, and at the same time, provide the kind of services that at the same time will produce results. It's challenging. Okay. So what are the elements of a well-functioning healthcare system? Do you think this is important? Good leadership and governance. Okay, now with your technology, having a health information system that's very efficient would help. There's a new field, relatively new field in health. This is health informatics. Okay, you might want to look it up, and it's one of the fields that you can go into. So if you're a medical professional and you're someone who's very interested in technology, computers, etc., you can go into this field because there's still a lot of things that you can do, especially with the advent of AI and the likes. You can go into health informatics, which will help improve the efficiency of the health information system of any health system. Of course, health financing, which is the lecture for this afternoon. Of course, the human resources, doctors alike, medical allied professionals, your nurses, paramedics are very important. Okay, and production of your essential medical products and technologies, production of drugs, production of vaccines, and the like will build your healthcare system. Of course, it's not enough to produce all of that. If you cannot bring it to the countryside or to bring it to the most people that will need it, your service delivery will not be felt by people. Okay, let's have them one by one. Okay, leadership and governance. So it ensures that health authorities take responsibility for steering the entire health sector, which deals with future and current problems. So it should be anticipatory. Okay. They say we should have anticipated the pandemic that it will happen again. But since the pandemic before this happened almost a century ago during 1918 of this magnitude, we were struck on unaware. But every time there is a possibility that there is an emerging disease that could threaten mankind. Okay, or war, nuclear war, World War III. And it just takes a flick of a nuclear bomb to wreak havoc on another country. And there are countries that are capable of doing that. Is India capable of launching a nuclear war? Yes. Oh my God. I'll be good to you. Joke, joke. Define policies, strategy, and plan that set a clear direction for the health sector. So policies which we will have next meeting would be important. Planning and strategizing so that your health system will have a clear direction. So what are these policies? They're supposed to be people-centered, aims to distribute health as equitable as possible. Remember, there's difference between equitable and equality. What's the difference? What is equality? What is equity? So rich and poor, for example. In equality, there is 100 pesos gain between someone who is rich and someone who is poor. Inequality, how will it be divided? It will be divided 50-50. Okay. For equity, how do you think will it be divided? The one who will need it more, the poor person who will benefit more from the aid will get more. The rich will get less. For example, 80 will go to the poor, 20 will go to the rich. Fair and fair. Depends on how you look at things, right? But that is how equity works. Again, your aid is for what? It aims to give support to the marginalized and those who are oppressed. Again, if you will look at a framework of capitalism, that patient is poor because he did not exert effort. Why will I get punished? That's often the argument of rich people in this world. Why will I get punished if I work myself off so that I can be where I am at today? And these poor people are just depending on government, spending the taxes that the rich person pays. And when there's aid, who does the tax goes to? Tax relief goes to the poor people, leaving the people who paid the tax. This has happened when there's COVID. The one who is in need. Again, a dilemma. There's no right or wrong answer. There's no right or wrong perspective. You just have to look at all angles so that you can make public health policies that are sound, effective, and has accountability. So that you can see implications of financing. You can look at the implications it has on human resources, pharmaceuticals, technology, and infrastructure. There should be a mechanism for accountability and adaptation of evolving needs. Of course, regulation is important. Making policy with other sectors, mechanism and institutional arrangements to channel donor funding and align priorities. Okay. So good governance is only possible with good information on health challenges. Of course, if you do not have the correct information, you will not be able to make good policies. You will not be able to make good decisions. So that you can meet health challenges and the objectives through how do you get data? So we go back to research, to go proper surveys, look at your civil registries, look at your epidemiologic surveillance. Okay, again, if there would be bias, of course you will not get accurate data. Health financing. So these are often barriers to health services for the poor and vulnerable. Strengths and needs for human resource, use of pharmaceuticals, cost of technology, and distribution of infrastructure, as well as access, care, and the quality of services provided. As part of it would be monitoring and evaluation plan that specifies core indicators, your targets, how you collect data, analyze, and communicate its use. Of course, information should be accessible to all, including the communities that you got it from, civil society, the health professionals, and politicians. Okay, remember your COVID statistics. For a while, it was alarming because at the start, since my brother was a military doctor, more or less I knew the correct statistics that was not publicized. And it was very far, especially at the start. That March, the one that just started the lockdown, it was very doctored so that the public will not be alarmed. Okay? But the public deserves to know the truth. And you have to show the correct data. Okay. Of course, your human resource, health workforce is very important. That's why when there was a pandemic and there were a lot of doctors and medical professionals who were having second thoughts on going out. Right? There were a lot of doctors who were forced into retirement, especially those who were quite old, those who had morbidities and the like, those who had loved ones who did not make it because of COVID. Of course, you couldn't blame them if they stopped practice. Same with the nurses, same with the medtechs, etc. And of course, you have to have your workforce that will work for you. Okay? And what did some people get? A hazard pay that was almost non-existent. And some doctors were even bashed during the pandemic because we were the only ones who can go out, and we were the only ones who had more or less an income because everything else was a standstill. But you have to provide PPE, provide safety, etc., which some governments were able to do. Philippines quite slow. So that you can have a well-performing workforce that will be responsive to the needs of people. But yes, as doctors, even if there were no PPE, we make do. Why? Because some doctors will not forgo their calling. Okay? I had diabetes, I had morbidities, but I had to go out. I cannot tell my patients don't go into labor because like it or not, the baby will come out after 9 months. So I cannot say, oh, there's pandemic, do not get pregnant or do not deliver first. Yeah. Yes, I feared for my life. I had COVID, but I was already vaccinated. Yeah, unfortunately, I got it from my brother who brought COVID home because he operated on a patient, non-disclosure that the patient had COVID. Okay, that's why it's important. Make sure your doctors are compensated either economically or professionally. So arrangement for achieving sufficient numbers, diversify and competencies. Now, the aim is for everyone to be able to deliver primary health care and veering away through specialist intervention. Payment systems should be regulated. For example, PhilHealth. Sometimes PhilHealth is operated on a patient, the compensation comes 2 years after. The baby is already 2 years old before I see the PhilHealth payment of the patient. Okay, that's bad. Or if ever I do see reimbursement. Regulatory mechanisms to make sure there's a wide deployment. Okay. A problem in any country, even in the developed countries, the doctors are in the centers or in the cities. And it takes a lot of encouragement and a lot of benefits for one to practice in the rural area. More often than not, it's compensation, it's an ability to study while having residency in a far-flung area, etc., for most. But it's important to provide health services for all and not just for a central city or to the main cities. Support systems, regulated norms, and enabling work environments. Okay. When you become clerks and interns, you might be, if you haven't have an idea yet of a 24-hour duty that prolongs into a 36-hour duty, because you go on duty 7 to 7, 7 a.m. to 7 a.m. the next day. Do you think you can go home at 7 a.m. the next day? Not always. So you are still to stay until 5 p.m. That is what happens. But now, especially for the interns, there's a rule. You can only go on duty 12 hours. You go 7 a.m. to 7 p.m., then you go home. Because studies show that sleep deprivation would make you less effective, etc., etc. But then again, there are a lot of cultural things that happen in the hospital as a workplace that you will get to know once you're there. And some, I will say, will be good practice, some will not. So it's also up to you if you want to propagate that practice. If you want to propagate that practice, if you feel that it's part of training, then go ahead. But if you feel that it defeats the purpose of being in a workplace and it degrades you as a person, of course, you balk and you complain. But then again, it's hard to break the system. It takes a lot of courage as well. Okay. Mechanisms to ensure cooperation of all stakeholders, such as your health worker, advisory groups, donor groups, private sector. So it's a collaboration of all groups so that you could you could provide good human resources for health. Of course, your essential medical products. Universal access to healthcare is dependent on access to, of course, affordable medicine, vaccine, diagnostics, and health technologies. It's useless if you have your doctors, your medical professionals, but you don't have the medicines, the equipment to have it. Okay? So that you can assure quality and be cost effective. Okay. And they're the second largest component of most health budgets after your personnel. And the largest component of private health expenditure in low and middle income countries. So they spend for drugs, they spend for vaccines, they spend for procedures, diagnostics, and the like. So this is also an important aspect of the industry that you have to know. Okay. It has to be regulated for marketing authorization and safety monitoring. Of course, this is backed by legislation, how it is enforced, so that access to medical products are ensured quality and accessibility, such that there's a national list of essential medical products. If you're on the national list of medical products, so standardized equipment to produce, used in treatment protocols, and most importantly, it can be reimbursed through insurance. Prices are regulated. So there's a reason why a drug would not exceed 20 pesos per tablet because it's regulated. Otherwise, especially if your drug is the only drug that's there, then you can price it any way how much you like. Supply and distribution system to ensure access to essential medical and products and health technologies through public and private channels. Okay? As I've mentioned, price is monitored and rational prescribing. This is what you will also learn when you become doctors. You will be courted by drug companies left and right. What do I mean by courted? they will buy you. They will buy you so that you can write the prescription. How do they buy doctors? By a lot of things. And you will be amused on how they will give you convention tickets, they will give you travel tickets, they will say, oh, there's a research and development forum. Or you will be surprised, where is the research and forum development, etc., etc. Doctor, it's in Korea. Then you have a plane ticket. But there's no such thing as free lunch. What's the expectation? That you will write out a prescription for their job in exchange. Hard to resist for most. Okay. But again, please do remember rational prescribing. You only prescribe when the drug will benefit the patient. I know of one debut or birthday party of the daughter funded by the drug company. Things like that. But now it's quite regulated. Sponsorships are very regulated, not so much. But when I was growing up, that's the usual thing that I saw. Service delivery are only effective because they can provide services. So as close to the client, that's why we're doing primary care. You provide package of benefits. And of course, up to par to certain standards. Okay, of course, you have mechanisms to hold people accountable for access and to ensure quality. Okay. So this is a scorecard and you look at different aspects to look at if your health system is doing fine. So you look at accountability, you look at clean water, energy, equitable education, good health and well-being, business and investment promotion, disaster resilient community, peace and order, clean and livable environments. Okay. So this would be your scorecard for health. So for categories, you can look at the following. So it's either financial risk protection. So what are the components? Governance for health. And you can look at the objective. So what's the objective? Increase LGU investment for health because you are looking at finances. So look at your budget allocation, you look at your LGU allocation, you look at your expenditures. Same way with the others. You look at the quality of hospitals, you look at the physician ratios, you look at your MDGs, you look at your indicators. So they are different. Okay? So the second part would be more on economics. Why? Okay. Like it or not, you have to be averse of these terms. Well versed with what is your gross national product? What's a gross domestic product? So it simply is the sum of the total of three components. Okay, so personal consumption, expenditure on goods and services, and investment expenditure. Okay. Okay. So gross domestic product by definition is an estimated value of the total worth of a country's production and services calculated over the course on 1 year. So this is what's nice. So this is consumption plus government expenditures plus investments plus exports plus imports. The gross national product, on the other hand, is the total amount of goods and services that a country's citizens produce, regardless of where they are produced. It's the South. The other one. So GDP is calculated by adding up the market value of all expenditures on final output. So consumption, amount consumed by private residents, investment, the amount put aside by private firms to build new equipment, government purchase, the amount issued by the government, and current account balance, the amount of net exports of goods and services to foreigners. Okay. Per capita, and this is where your India falls. Per capita by head, meaning to be determined by the number of people. So, for example, in India, there's a big population, right? So, by definition, if you will be talking about per capita, you will get a smaller part of the pie compared to a country with a smaller population. That is why you will see in the top 10 health systems, you'll not find India. You'll also not find China. Mainly because it is divided into per capita. Okay. To find the per capita cost, see, total number of persons are added up and the bill, tax, or benefits are divided equally among those persons. So naturally, if you have a larger population, you will have a smaller part of the pie. Such that, that's the word, per capita. And the ones who are having a bigger per capita income would be, you will see, most of that would be smaller countries. Okay, Macau is a small country. That's not China per se. Okay? In anything, there's devaluation, depreciation, and inflation. And this lowers the value of anything, a currency within a fixed exchange rate system. Okay. So what your 1,000 pesos could buy you when you were in first year could not buy you the same thing now. Correct? 1,000, what could bring you 1,000 3 years ago? Now that will only last you how many days? That 1,000 pesos. Because the exchange rate, floating exchange, changes fluctuatingly. And that erodes the purchasing power of money. Thereby, health economics can be broadly defined as the application of the theories, concepts, and techniques of economics to the healthcare sector. Excuse me. Okay, allocation of resources between various health promoting activities, determination of the quantity of resources used in healthcare delivery to improve health, organization and funding of health organizations, and efficiency of the allocation and use of resources for health. Assessing the effects of preventive, curative, rehabilitative health services on individuals and society. So that is the definition of health economics. Okay. And it's a cycle. So if you have no personal income, you will not have access to food and safe water. You will not be healthy because you will be hungry and there's poor sanitation, which will result in disease and malnutrition. And you will not be a productive member of society. And if you cannot be a productive member of society, you will have economic decline individually and as a community. And lower personal income again. So it's a cycle. And it's hard to break out of that cycle unless there's an outside force that's willing to intervene, such that the relationship of health and economics hinges on an improvement of health status in general. How? It improves work productivity, it provides better economy, and you have to allocate more resources for it. Okay. Is there attendance? Is there attendance passed around for section B? None? No. Okay, the have the tutor. Okay. So total health expenditure based on percent GDP. Okay. Okay, if you will see, based on gross domestic product, highest health expenditure would be United States. The average would be around 9. Is India somewhere there? India is here. See, very far. It's at 3.6. Again, if it's per capita, it's really affected. China is also on the right-hand side, I saw, but quite higher, 9.4. Percentage of government spending in health as per total health expenditure. Okay, you see how bad Philippines would be, just 1.4 of total government spending out of the total budget. Okay, most of it goes into education, public works, debt service. Even if the Philippines would have a 5.268 trillion budget for 2023. Okay, and this would be the division. Out of the trillion, how many would be allocated to the health sector? 296 billion. But again, this would be inflated to think that this would already be accounting for your COVID pandemic. Okay? Had the pandemic not been existent, I'm sure this would be lower. But because we are still in a pandemic state, budget for health is quite high compared to historically what it is. Okay. So this is the percent expenditure to current health expenditure 2021. So most would still be out of pocket. Half would be government schemes. Voluntary healthcare payment systems would be 8.2. Of course, in health economics, there would be cost of disease. Okay. Benefits of health programs and investment returns as far as medical education, training, and research would be concerned. So it determines the price and quantity of limited financial and non-financial resources devoted to the care of the sick and promotion of health. Okay. For the pandemic, the vaccine would, for the individual, would have no cost, right? It's provided free because it's a medical emergency. Okay. But for every vaccine, remember that produced something to be produced, that costs something to be produced, that costs something to be procured. Okay, imagine India, 1 billion population for ease of counting. You have to vaccinate, for example, 1 billion people. Just to think that the vaccine will cost 1 lakh or 1 peso. It will already cost you 1 billion. And you know that will not cost 1 peso. And you could just imagine the amount of money, health economics factored in for government to be able to provide the vaccine for everyone. And yet, people didn't want to get vaccinated. For the Philippines, the government acquired vaccines to vaccinate a lot of people. What happened? Because of fear, the vaccines got expired, or the Philippines had to donate what they procured because it will expire and no one wanted to get vaccinated. Okay, what happened? That's why people got vaccinated here. They threatened not to admit people in SM if there's no vaccination card. Suddenly, people went in droves to the vaccination centers to get vaccinated. That's what happened. That's what happened come January. SM will not admit, the malls will not admit if you don't have vaccination card, at least 2. And people suddenly had themselves vaccinated. Do you think that's the correct reason why you get vaccinated? But again, that's how policy works. And that's the magic of policy. Why? Because you have to look at the culture of the people that you are working with. And that is what makes people move. And that is what made people feel threatened. Oh, if I don't get vaccinated, I will not have access to SM. Let's have vaccination already. And that is knowing who your people are. Again, it's not the right reason, but it's the right step. At least people got vaccinated. Your end goal, you achieved it. Okay, so again, you have to look for a lot of ways. Sometimes it may be unorthodox. You think out of the box. And you will, it's not always point A, you go to point B. Sometimes you go a lot of detours before you end up with where you are supposed to be. And that also applies to real life. What's the main aim? Quantity over time, the resources used in health service delivery. Organize, allocate, and manage health resources in such a way that they are used. Yeah. This is preventive medicine. Preventive, curative, and rehabilitative. Of course, it is more cost-effective if we prevent than cure, than rehabilitate. So that we achieve optimal individual and national productivity. Again, a healthy citizenry is a productive citizenry. Okay, I always tell, if I'm an ordinary work person, I would be out of the job. I wouldn't be able to find work because I have a lot of sickness. I'm diabetic, I'm hypertensive, I'm asthmatic, etc. etc. And I have to be healthy. Okay. So when you look at economics, you have these terms. Cost minimization. What does cost minimization mean? Lowest opportunity cost for a given activity. So you are able to do things at the lowest possible cost or acquire things at the lowest possible cost, but not always the best. If, for example, when you buy shoes, there's a 100 peso shoe, there's a 500 peso shoe. But the 500 peso shoe will last you longer than the 100 peso shoe. Will it be cost minimization if you buy the 100 peso shoe, but it will get destroyed after 2 days? Not always. So you will look for cost minimization, but also at the same time, quality. Cost benefit. Estimating of costs and possible benefits derived from the invested resource. So how will you benefit from the investment? So here it's like your cost minimization. If it's not effective, then it cannot be cost. If it's not worth for the money, then it's not cost effective. Comparison of cost and health effects of an intervention to assess the extent to which it can be regarded as value. So cost minimization, you get for the 100. But using the definition of cost effectiveness, you will not get the 100 peso shoe. Cost utility. Determined in cost in terms of utilities, especially quantity and quality of life. So even if it's expensive, if it will make you happy, then you go. So it's different for different people. Some will find happiness at the simplest things. Okay. Some will find happiness, they want expensive stuff. So depends. Quantity and quality of life is hard to define. Again, difficult to put value because health status as perceived by different individuals. Okay. So like it or not, there's some computation. ACER. What is ACER? It's an average cost effectiveness ratio. So it's almost equal to healthcare costs over clinical outcome. So what does it do? It represents. So the total cost of a program or treatment alternative divided by its clinical outcome to yield a ratio representing the cost for a specific clinical outcome gain independent of comparables. Compared to ICER, it's incremental cost effectiveness ratio. So you're comparing cost A minus cost B over effect A minus effect B. So additional cost that a treatment alternative imposes over another treatment is compared with the additional effect, benefit, or outcome it provides. Okay, so for example, average cost effectiveness ratio of drug A. If you will look at your average cost, 165 over 0.56, treatment success will cost $294, etc. Of drug B, $212.96. If you will compare the incremental cost, if you add drug B to drug A, there's a $30 additional treatment cost for success. So are you willing to pay that price? Okay. Just a little food for thought. Okay. Scarcity. So health needs, whether perceived from the angle of the professional providers, are infinite. Whereas, again, we will know later in our latter discussions, resources are limited. Okay. Welfare governments try to ensure that economic thinking is built more closely in the planning and decision-making process. Okay. Keeping the concept of scarcity in view. Okay. Of course, health needs are endless, but health resources are not. Okay. Remember your pandemic in India at your Delta peak? What happened? Hospital beds and oxygen tanks were scarce. So even if you can buy or you can afford to be admitted in the hospital, they were simply not able to accommodate anymore and people were waiting outside. Scarcity of beds, scarcity of human resources, scarcity of equipment, especially if demand becomes unnecessarily high, especially with your pandemic. Type, quantity, and quality of services wanted or requested. And at that time, most would be needing oxygen tanks and hospital beds and be quarantined, such that the demand of medical care is always a function of consumers' income, the price of medical care, and preference of consumers. Okay. You have your poverty line, and this is your cut-off point of income below which people are not able to purchase food sufficient to provide 2,400 calories per day. So they're generally defined in terms of minimum per capita consumption level of the people. Again, if it's per capita, that brings down um, numbers. Okay, so this is Philippines number. So minimum wage earner would earn around 491 a day. Now it's around 512. Okay, so at that would be 11,000 per month less. Take home minus deductions, take home pay would be around 9,800. So you would be having to budget 326.72 per day. If you're the head of the household, that's per household. For a worker who is single with no dependents. More so if you are someone who has family. Okay. So poverty statistics. Food threshold. So the minimum income required to meet basic food needs and satisfy the nutritional requirements set by the food research to ensure that no one remain economically and socially productive. And there's a poverty threshold expanded to include basic non-food needs such as clothing, housing, transportation, health, and education. You're living here as single, non-dependent. Would 10,000 last you for the month? Or you will live like a king for the first 3 days and then you will live with noodles for the other days? Budget. So you have to know how to budget. So it's a systemic economic plan for a period of time so that you can ensure that your program decisions become good decisions. So your spending will be planned. You have to know how to allocate your resources properly. both in monetary and non-monetary sense within a program. For your allowance, you learn to budget it. How is it given to you? Per month or for the whole semester? Do you bring all your money here when once you go to India, or did they send it to you? They send. You budget it until the next send. Or non-resources, your time. How do you spend your time studying? You allocate. Okay. Again, top 10 departments, most of the money is for debt servicing. DOH, just a partial. Okay. At financing, you have raised resources to pay for some sources of healthcare financing, of course, would be your government sources. You have your private donations. You have external cooperation or aid, individual or household or mixed sources. Okay, some major problems would be lack of funds, unequal distribution of health finances, rising health costs, lack of coordination in health financing units, and inefficiency. Of course, out of pocket. An individual pays a health provider or facility from his pocket each time he avails of medical services. What's the advantage? He only pays when he needs the service. If he does not need service, he not pay anything. Okay. Disadvantage. It was a one-time, big-time thing. Because if it's out of pocket and you need a large amount, you may have difficulty providing or looking for sources. Compared to insurance, an insurance is an individual which pays a premium which will cover his hospital expenses up to a certain limit for a period of 1 year. Advantage, you're paying a small amount which will assure him of a big coverage enough for a year. Okay, what's the disadvantage? If you are not getting sick, you will not be able to use it. So it's like you paid for a premium, but you did not avail for the service. Okay. So these are risks. Risk on the individual not to be able to use the coverage within the period because premiums are not refunded. Okay. That's why in the hospital setting, you will also see people who have cards will go to consult with no problem. They just want executive check-up, etc. They will say they have problem, but actually there's not. What has happened? Risk on the insurance company. Overutilization of coverage. So this is over consult because of card. Increase in the prices of hospital and surgical care because of so your health maintenance organizations. So the consumer pays a premium which will give him a comprehensive healthcare program of benefits. What happened? Happen. Can you? Right? Okay. Okay. Sorry about that. So the consumer pays a premium which will give him a comprehensive healthcare program through a package of benefits. So this is not merely hospitalization coverage, but a complete preventive, curative, and rehabilitative package. So what's included? Annual physical exam, outpatient benefits, preventive, inpatient coverage, emergency coverage, and the like. Okay. Some will include, but not all. Okay. So you have effectiveness in resource allocation and utilization. So government spending is skewed towards hospital care. If you like it or not, it's still tertiary care being focused on by the government because they still see it as cost-effective, preventive, and public health programs are often underfunded. Okay. Offshore referral costs excessively high in other countries and provider-induced demand for profitable goods and health services. For example, pharmaceuticals, drugs, and high-tech diagnostics services are the ones. Insufficient public spending on health. Resources are limited. Because of this lack of resources, some are forced to reduce budget, thereby increasing out-of-pocket pay through how is it done? Either formally or informal in taxes. For example, for the Philippines, they increased PhilHealth. Even the doctors have increased PhilHealth. So we provide service, yet we are still heavily taxed by our own national insurance. So absence of financial protection, particularly for the poor, low efficiency as far as allocation and utilization of resources are concerned, and lack of reliable data and information. Okay. Problems. So there's a quality problem of healthcare. You want it more, but costs continue to rise, putting healthcare out of reach in the for the ordinary person. We still remain to be curative and unable to meet our health needs because capacities are either not inadequate or interventions are inappropriate. And the effectiveness of your decentralized primary health care is compromised because it will depend on the willpower of the local government and coordination and cooperation among the local government units. Regulation is also a question, and while resources for health remains inadequate, the funding that is available is inefficiently generated and inequitably spent. Okay. Okay, so the last would be your health sector reform agenda. So I will leave this to you because this would be strategies 2011 to 2016. This is just an example of a health system plan for as a national strategy. Okay, so this is your national health insurance program. This is the PhilHealth program of the Philippines. Okay, some definitions and some coverages. So this is for your just browse through it because this would be Philippine insurance. So not your concern much. Okay? So that you can just compare it to Indian National Insurance. Okay? Any questions for this afternoon? Read out a piece of paper for for the ones on Zoom. Um, the link I forgot to put. In the YouTube live, you look for this live video and you comment your answer so that I can check. For the ones here, right? Or you want to comment na lang din also? No, no. I want to see who is here. Piece of paper, submit 3. Comment, for the ones on Zoom, comment 3 things that you learned for this lecture. On paper, for the ones here, submit 3 things that you learned for this lecture. Okay? I will send the YouTube link to your class.